Let me add my welcome. I'm Fred Osher with the CSG Justice Center, and it's such a privilege to be led by Representative Colleton, to have the guidance and support and funding from the Bureau of Justice Assistance, and to be a part of this next day and a half in which we hope to, as a collective body of wisdom, share information that will improve our ability to create better responses to those with mental illness who contact the justice system. And we start today with a keynote speaker that has the ability to assist in guiding and understanding the aligning people and programs portion of the agenda. It's my privilege to introduce Dr. Jennifer Skeem, Associate Professor, University of California at Irvine, works there within the Center for Evidence-Based Corrections, has been a longstanding member of the MacArthur Network on Mandated Community Treatment, recipient of numerous professional awards related to her work, and most importantly relevant to this audience today, as much as anyone has, through her work and her research, helped us understand the connection between people with mental illness and criminal justice involvement. I trust that you'll enjoy the presentation. I've heard several presentations before from Dr. Skeem, always learn a lot, and please join me in welcoming Dr. Skeem.
Good morning. It is a pleasure to be here today. I'm honored by the invitation. The Council of State Governments I really see as a leader in the field, and through these collaboratives with BJA and others, has made really significant impacts in the area of criminal justice and mental health. And I'm especially excited to talk with you all, the next generation of grantees who will be doing frontline work on this important problem. So Fred gave you an idea about the topic of focus for my talk. Most of you, probably all of you, are very familiar with this very high-profile incident, which one of these high-risk incidents were referred to during the introduction. So this incident and others like it over the past several years have raised a lot of public awareness and a lot of public questions about the adequacy of both risk assessment and treatment services for people who ostensibly have serious mental disorders. So the questions that got raised with this case were many, and it is always the case that with these incidents, they're very, very high profile. They're very, very rare. And by these incidents, I mean mass shootings like this one, or the Virginia Tech shootings with Cho several years ago. So the question that is raised is, could someone have foreseen this and prevented it from happening? Could college officials or psychiatrists or whomever have predicted that these violent acts were on the way and taken action somehow to prevent them? Hindsight is 20/20 in these cases. If we get more to the point, in this case, the question that's raised is, if Jared Loughner had been provided with psychiatric treatment, would that have prevented this from happening? My hope is that by the end of this presentation, you're not sure. I'm not sure. It could be the case that what was needed here was psychiatric treatment. It could be that that was part of the picture, but there was more to it. So this is why, when we look at the case-by-case level, we have to decide whether someone is criminally responsible for their crimes on a case-by-case, crime-by-crime level. So I start with that reminder, and then I'm going to scale way back because I'm a scientist and that's what we do. So what I'd like to do is really remind you about what we mean by evidence-based practice. How many of you are tired of this phrase? I am. I'm tired of this phrase. It doesn't matter whether you hail from medicine or law enforcement or corrections or academia, especially in an era of budget cuts, everybody wants to do what works. So we start by saying that what I mean by evidence-based practice is we are applying the best research, which I'm going to talk about today, at least a little bit. So we're applying the best research to inform practice that improves outcomes. So it's very outcomes-oriented focus. And I'm going to assert that for our purposes, what will make programs most sustainable right now is the public safety outcome. So having fewer new crimes and fewer new victims is really important. Public health outcomes are also incredibly important for this group, but I believe that public safety is the goal that we should strive to reach first. We have to add to this in the current era that we're dealing with the real world here. So it's not just what works. We certainly can have Cadillac models of what works, but the things that will be sustainable are those that are optimal, which is defined here as the least extensive, intensive, intrusive, and costly intervention capable of successfully addressing the problem. So with that background, what I'd like to talk about is what we've learned so far about general principles of treatment and supervision that may really help when it comes to public safety outcomes for individuals who have serious mental illness. So I will start by talking about the problem with which you are all familiar because you've written grant proposals about this. Briefly touch on contemporary attempts to solve the problem, whether they are mental health courts or specialty re-entry programs for those with mental illness. And I'm going to advocate what is already happening here. The Council of State Governments, again, is really a leader in this field, and it's really refreshing, exciting to see the program that you all get to take advantage of this year, because there's really a shift already in moving beyond kind of a one-dimensional, very mental health-focused approach to the problem to consider what the other contributors are as well. And then I will boil down to probably 3 recommendations for practice. Okay, so first, the statement of the problem. We've already heard this in many different forms, but the issue is that people with serious mental illness are overrepresented in the criminal justice system. There are old data that are still good data that are available on this topic. When I say serious mental illness, I'm really focused on depression, schizophrenia, and bipolar disorder. So if we look at the prevalence of those disorders among men, your neighbors, your family, in the community, we see that the prevalence rates are really pretty low, under 2%. All we need to do is set foot into a jail, in this instance, Cook County Jail, and we see that those rates can triple. For women in your community, again, your friends, your neighbors, your wives, your sisters, we see that the rates of those mental disorders are actually higher, mainly because we're more prone to major depression. But again, if we step foot into Cook County Jail, we see that those rates double. Fred Osher, Hank Stedman, and others updated these numbers recently and kind of attached them to representative figures, and they estimate that about 14% of men and 31% of women in the criminal justice system suffer from one of these major mental health problems. Now, on the surface, it may not seem like those are big numbers, but they become big when you put them in context. The first way that we can do that is by considering that if you take any one of those individuals, the odds are pretty high that they will also have a co-occurring substance abuse disorder, which we know complicates the picture for everyone, but particularly for those who are mentally ill. We also need to place this in the context of what's been happening in our correctional system over the past 20 or more years, which is it's been bursting at the seams. So we now have over 7.3 million people under some form of correctional supervision in the United States, which, if you're doing the math, that amounts to about 3% of our population. It's huge. If you look under the surface of those numbers, you can see that by far the workhorse of the system is probation. So that's the most common disposition. If you put probation and parole together, you've accounted for most people who are under correctional supervision. I'm pointing that out because most of the research that we've done focuses on community corrections. One of the reasons for that is because there are so many people in community corrections. The other reason for that is it's a real testing time. We know that interventions are more effective when they're applied in the community than when they're applied in institutions. So in many ways, we have the most chance for help in those settings. At the same time, we see that when it comes to folks with mental illness, there's a long way to go in terms of improving outcomes. Because if you're a probationer or a parolee with serious mental disorder, your odds of failing community supervision and often returning to custody are about 2 times higher than if you don't have a mental illness. So we do focus on probation and parole, although a lot of these principles will also apply to people in institutional settings. So we have a lot of people with serious mental illness in the criminal justice system. The criminal justice system is bursting at the seams, and we have many folks with mental illness who are not doing well in the system and tend to fail. As part of the Consensus Project years ago, the Council of State Governments brought people together to really focus attention on this issue. And as they stated, the current situation not only exacts a significant toll on the lives of people with mental illness, their families, and the community in general, it also threatens to overwhelm the criminal justice system. So that's why we're here. And many of those are facts that you already know. The next step is, what are we doing about it? What have we done so far, and what can we learn from those efforts? One of the things that the Consensus Project did was to really distill what the consensus view was about the root of the problem. Why is it that so many people with serious mental illness are found in the criminal justice system? You all probably have implicit responses to that. I had my own when I began this work, and it went something like this. People on the front lines every day believe too many people with mental illness become involved in the criminal justice system because the mental health system has somehow failed. They believe that if many of the people with mental illness received the services they needed, they would not end up under arrest, in jail, or facing charges in court. So this is the implicit view about the root of the problem. Given that that's seen as the root of the problem, what do you think is viewed as the key? You can talk. Getting them help. What kind? Mental health help, yes. So given that that's perceived as the problem, the key is really framed as linking these folks with psychiatric treatment. We saw this in part with the Loeffner case. So why is it that he wasn't provided with medication, linked with services, etc.? So the notion, and this is a model that really you can see in different forms for any program, is that what we need to do is use the criminal justice involvement to mandate the person to psychiatric treatment. The reason for that is people with serious mental illness and co-occurring substance abuse disorders are not always the people who wake up one day and say, today's the day, I'm going to stop drinking and go to treatment. So the idea is you could use this mandate to get them services that they otherwise wouldn't have or wouldn't have enough of. And that is seen as the route to reducing recidivism. So it's not only seen as the means of reaching the public health goal, but also, therefore, the means of reaching the public safety goal. This is a model that you see hints of whether we're talking about mental health courts, CIT programs, specialty probation and parole programs. Virtually all of them share this emphasis on linkage with psychiatric treatment. But what I'm here to show you is that research actually suggests that the root of the problem is more complex than that, and that it may take more complex solutions to really make a dent in the public safety outcomes. To just give you a couple of hints about this, we found in some of the best research, so experiments where people are randomly assigned to either state-of-the-art mental health treatment or treatment as usual, we found in some of those studies that psychiatric services do generate the public health outcomes that they're supposed to, so reduced hospitalization, better functioning, etc. But those outcomes don't always translate into reduced likelihood of arrest or reduced recidivism risk. And there are examples of that with assertive community treatment, which is sort of the Cadillac model of treatment in the sense that it's expensive, intensive, and has been shown to work very well with people who are seriously mentally ill. But in this study, it didn't translate into reduced recidivism. It's also, more surprisingly, been true in at least one study of integrated dual diagnosis treatment. So the next thing that I want to share with you is that there are forensic adaptations of some of these evidence-based mental health services. For example, forensic assertive community treatment explicitly makes the criminal justice outcome part of what they focus on as their job. And there's more mixed evidence for whether these are effective. Sometimes they're shown to be effective, sometimes they're not effective. Same thing with mental health courts, sometimes effective, sometimes not effective. Specialty mental health probation, we have less research here, but we're finding that it has been effective. But it's not effective for the reasons that we assume, not all the time. And that's what I want to share with you. I think that if you go beyond just finding out whether what you're doing is working, to drilling down to determine why it's working, you will be in much better shape. If we have principles of effective treatment and supervision rather than packaged programs, I think we'll be miles ahead in terms of really making a difference for this population. So back to specialty mental health probation. I'm going to tell you quite a bit about that because it's what I know the most about. In a study that compared specialty mental health supervision with traditional supervision, we found that specialty supervision really worked. We actually found pretty good effect sizes for reducing arrest, which I'll share with you later. But when we looked and evaluated the logic model that's under specialty probation and under mental health courts and under a lot of other things, what we found is that symptom reduction wasn't the reason that it worked. So this is a graph that data is our friend, it really is, so don't tune out. So what we found here, this is a slope score. What that means is we followed people for a whole year and we measured when they started probation, 6 months later, 12 months later, where were their symptoms? Were they the same across that year? Were they going up, meaning they were getting worse? Or were their symptoms coming down? They were actually improving. What we found is that if we compared how much symptoms were changing as a function of whether people succeeded or failed supervision, there was no difference. So you can find people who succeeded in probation, who had lots of symptom improvement. So their symptoms came down by 3 standard deviations. That's huge. They got way better, and they didn't get revoked. The problem is that's not statistically different from people who did get revoked. You can find people who got better and nevertheless failed community supervision. And this is true not just in this study, but also in some recent state-of-the-art multi-site jail diversion and mental health court evaluations that Hank Stedman and others have done. So it's maybe not for the reasons we expect. I think part of the reason for this is we need to be more careful and realize that actually, if you take the people who are before you in your programs, you realize automatically that they're not all cut from the same cloth. For some individuals, mental illness probably does lead them directly to criminal behavior. For many others, it may be more complicated than that. We know that from 3 studies now. I'm going to tell you about one of them. This was a study done by Junginger and colleagues. It was based on a jail diversion program in Hawaii. They took 130 or so people who had serious enough mental illness that they were deemed eligible for this jail diversion program. What they did in this study was simple but clever. They talked with the people who had been booked within 7 days of booking, so they interviewed the offenders. They talked with the police if they were available and always reviewed the police reports. What they were interested in determining was, what was the reason for this arrest today? So taking this one incident, to what extent was this a direct effect of mental illness? Meaning maybe the person had paranoid delusions and they just did a preemptive strike and hit somebody that they thought was going to hurt them. Maybe they were hearing voices that led them to take something, right? So how often was it direct effect of mental illness, or maybe an indirect effect? It could be that someone's depressed to the point that they can't get out of bed, let alone go report to their probation officer. So that would be an indirect effect of mental illness. What they found is that in the sample of over 100 people with serious mental illness, 4 of them 4, had been arrested that day, probably to definitely, as a direct effect of their serious mental illness. When we add indirect effects, we get another 4, which gets us up to about 10%. This is consistent with other research. We've done reviews not just of single incidents, but of lifetime histories of parolees who have mental illness, and have found that probably 10% to 12% of them do have patterns of crime that you can link directly with their mental illness. They're survival crimes, they're linked with delusions, hallucinations, etc. But for the rest, they seem to have patterns of crime that are disordered, but shared with their relatively healthy counterparts. In this study, they also coded substance abuse, which could be a likely factor for this group. Again, 75% of them also have substance abuse disorder. What we see here that is about 1/5 of them, 20%, 1 out of 5, were high or drunk at the time they were arrested. And we get another 7% who may have committed a crime as an indirect effect of substance abuse. So maybe they robbed somebody to get money to support a drug habit. What we take from this as a whole is that, yes, mental illness is extraordinarily important for a subgroup of people. But there seems to be much more to the story for others. We're missing a lot of the variance, explanatory power, if we only focus on mental illness or even substance abuse. So for these reasons, we've been advocating that we move beyond assuming that mental illness is the source of and solution to the problem for offenders with mental illness, and adopting a bit more of a nuanced approach. There are alternative perspectives to the one that is dominant in the field. So an alternative to the belief that mental illness is the source of the problem and the solution to it, there are other views like this one. Bill Fisher and his colleagues said, some people with serious mental illness may engage in offending and other forms of deviant behavior, not because they have a mental disorder, but because they are poor. Their poverty situates them socially and geographically and places them at risk of engaging in many of the same behaviors displayed by persons without mental illness who are similarly situated. So this is not necessarily my view, and I think it would be a mistake to replace one simplistic explanation, mental illness, with another, poverty. At the same time, I think it's really important to consider that, yes, mental illness may be part of the equation, but it may be really downstream. It could be that those with mental illness function poorly. They're more likely to live in neighborhoods where there are plenty of criminal models, there's a liquor store on every corner, etc. And some of those factors, and piecing apart those factors, become more important as drivers of their criminal behavior than maybe the mental illness is at this point. So we started wondering about this several years ago. That is, if mental illness isn't really a strong risk factor for crime and isn't a strong risk factor for recidivism, what is the explanation? And we began wondering whether it might be the case that those with mental illness have just more risk factors for crime than their relatively healthy counterparts. So in this study, we had a sample of parolees with mental illness, and we matched them with a sample of parolees who didn't have mental illness. And we simply assessed them on really strong shared risk factors for crime, which I'll show you in a moment. What we found was that those with mental illness not only had as many general risk factors for crime as those without mental illness, they actually had significantly more of them. And those factors were more predictive of whether they failed parole than were factors that were specific to mental illness, like what's their diagnosis, are they complying with treatment, etc. So what are these risk factors? These are called the Central 8 for criminal behavior. There is nothing holy about these. There's nothing magical about them. They just tend to show up in repeated studies as pretty robust predictors of crime, especially the top 4 here. Not surprisingly, if you've been very busy on the criminal behavior front from a very early period, you're likely to continue crime. So a history of criminal behavior is important. An antisocial personality pattern is important. I want to stop here and say something that's very key. I think, especially if you come from the mental health side of the house, we tend to write off people as soon as we see the word antisocial. And one of the things that I want to point out is that this is really just one way of naming, labeling problems that really are directly relevant to your group. So problems thinking ahead into the future, problems with impulsivity, problems with anger control and emotion regulation. A lot of these issues live under that label, which we use to call people names most of the time, which is antisocial personality pattern. Antisocial cognition, meaning feeling entitled to things that maybe other people aren't, having difficulty taking other people's perspectives. Antisocial cognition is a big risk factor. And finally, antisocial peers. If you associate with people who drink and do drugs and are involved in crime, your odds of doing the same are actually fairly high. We also have other factors like family and marital problems, poor school or work performance, poorly structured leisure time. Idle hands do the devil's work. My grandmother used to say that, right? And substance abuse. These are also, they're weaker, but still robust contributors to criminal behavior. And what we see is that across most of these risk factors, those with mental illness have these risk factors as much or more than those without mental illness. There are more recent studies, 2 or 3 of them, that suggest that if we look at criminal thinking scales, again, folks with mental illness have those issues as well as their relatively healthy counterparts. One other thing to point out. The reason that I use Don Andrews' figure here, that's where this comes from, is that it not only lists the risk factors, it also shows you how those are targets if you want to reduce the risk of recidivism. So there are correctional treatment programs out there that focus, for example, on antisocial cognition and have been shown to reduce recidivism by trying to develop less risky patterns of thinking and more prosocial behavior. Okay, so if we advocate a tune-up to the current model, this is what it would look like. We would basically say that we have the model that you saw before. This is in different form. So people are mandated to treatment. As a function of that, they get mental health treatment. It would be ideal if they got good mental health treatment, meaning the ones that have actually been shown to work on public health outcomes. And for a small subgroup, we are pretty sure that that will actually reach the policy goal. But the effects could get swamped because that is, in fact, a small subgroup. We don't know exactly how big it is, but I would say it's safe to say it's probably a minority. If we want to make a difference for everyone else, we need to add to the psychiatric treatment, not replace it, but add to the psychiatric treatment some principles from corrections that have been shown to work on public safety outcomes. So there are evidence-based principles like the risk-need responsivity model, which I'll define a little bit later, establishing firm, fair, and caring relationships with offenders, and using problem-solving instead of sanction threats. I'll define each of these. These, we have found, seem to help explain why some of the programs for offenders with mental illness work on public safety outcomes when they do work. So this is the way we would tune up the model, and I think this is beautifully reflected in your program for today. You have, as you will see, different workshops that focus on different pieces of that model. Now, if we take this apart, the mental health treatment part has been, I think, well covered. It's been a real focus over the past 5 years. So you can find entire toolkits on, do we still call them the Sacred Six? You can find entire toolkits on evidence-based practices for mental health that really help you piece apart how you can get to those public health outcomes. So integrated dual diagnosis treatment is one. Supported employment. I know Kim Muser is doing a presentation on supported employment later, which shows promise. We need to evaluate whether it can also get to the public safety outcomes. But if poor employment and poorly structured leisure time is a criminogenic need for an individual, then in theory, these things could help. There are also others that you can access there. What I'd like to focus on more is this box, because I think it's much newer in application to this population. So what do we mean by evidence-based corrections? Hopefully, most of you have heard about the risk-need responsivity model. How many of you have heard of this? Good. This is great. Okay. So the first principle, and I'll do this briefly since you're familiar with it. The first principle is that you focus your most intensive surveillance and your most intensive services on the highest risk cases. So if you're talking about cases who are eligible for release to the community, what we've learned is that your program is going to be more effective if you actually serve people who need your services. That can seem really counterintuitive to a lot of people at first. Why would I work with those jerks when I have this perfectly willing, able, compliant person that I'd like to spend time with over here? The reason is that perfectly nice person will probably continue to be so without your help. The higher risk cases that need your intervention, even if a few of them respond to it, you will get bigger returns on your group-based outcomes at the end of the day. The second principle is that it's important to target criminogenic needs. Criminogenic needs is just a fancy way of saying risk factors for crime that you can change. So you want to target criminogenic needs like the ones I mentioned earlier. Criminogenic needs vary from individual to individual. For some people, for a small subgroup, mental illness is a criminogenic need. But it's important not to assume that that's the case for everyone, because it's not. So it's key to really determine on a case-by-case basis, using state-of-the-art tools, which I'll talk about later. It's really key to figure out what factors are driving this person's criminal behavior. If I could target just one or two things, what would that be? And by the way, there are actually packaged programs out there. Given that criminal thinking is one of the leading risk factors and affects quite a number of people, there are lots of packaged programs out there that have been shown to reduce recidivism, like moral recognition therapy, reasoning rehabilitation, thinking for a change. They all have labels. They're all about equally effective if they're applied well, but that's one way of getting at something like antisocial attitudes in criminal thinking. The third principle, and the second R, is responsivity. This one doesn't have quite as much research support as the other two, but it makes a lot of clinical sense and seems important. The idea here is that what you're doing is trying to make the way that you offer supervision and services consistent with the person's background, needs, abilities, etc. So when responsivity is interpreted in the correctional literature, they usually say there's a general principle of responsivity, which is use cognitive behavioral techniques because they're structured, they involve homework, they're responsive to the learning styles of most folks who are involved in the criminal justice system. But I think it's also important to think about the principle of specific responsivity. And this is where you would have, for example, gender-sensitive programs, or you would address mental illness. Even if it's not a criminogenic need, it's important for people who have serious mental illness to be linked with services and to have those symptoms controlled. Why? Can you imagine putting someone with active hallucinations into a group-based treatment like reasoning and rehabilitation and expecting that they would pay attention and hopefully benefit somehow by changing their attitudes and thinking? These things can work together, is the point. Treatment for the public health outcomes and treatment for the public safety outcomes could, in theory, actually enhance one another. And the last principle, this is your biggest job, is to ensure implementation. If there's a huge problem in the correctional literature when it comes to reaching these public safety goals, it is on exactly that front. So you can have a program on paper all day long, but what really matters is what you're doing on the front lines with individuals and the extent to which that actually matches some of these principles of effective practice. Okay, what I want to do now is just show you a case in point. So we've done a big study of specialty probation. We found that it worked, and then we went beyond that to figure out why it worked. So I want to kind of concretize those principles that I've told you about. So to give you a little bit of a background, we found earlier that it wasn't about symptom reduction. So if that wasn't it, what we wanted to know was, what is it that's happening in the specialty program that's actually helping to reduce recidivism? So we've done studies of probation and parole. I'm going to focus on one in particular and tell you about 4 things that we think are important. The first is some of these programs seem to implicitly target criminogenic needs. This is an idea that we got early on where we would hear a mental health court liaison say, for example, what we really need to do is to get John to stop hanging around with his drug-dealing cousin. So even though mental health was the focus and psychiatric service linkage was a big deal, in some of these programs there were individuals who were really trying to get at what was driving the criminal behavior. The second is when you compare this to standard criminal justice interventions, these specialty programs seem to reduce how much they rely on sanctioned threats. And that seems to be really important, especially for people who have mental illness. The third is a core correctional principle of practice, which is in these programs, there seem to be stronger, firm, fair, caring relationships with offenders. The firm part is important compared to traditional criminal justice programs. And the fourth one is actually unique to this population, and that is we think that these programs can help reduce the amount of stigma-based decision-making that can happen, especially in community corrections contexts. So first, let me give you quickly the background. Many of the results are based on this study of probation that we're just finishing. The specialty site was in Dallas, Texas. They have a prototypic, state-of-the-art, award-winning specialty mental health probation program. Briefly, what this involves is offenders with mental illness are assigned to probation officers who manage caseloads that are significantly reduced in size. So the average is about 48. The officers have some background or interest or training in mental health. Many of them actually come from caseworker or mental health backgrounds. And there's sustained training in mental health issues. So that's different from traditional probation where mentally ill folks are assigned to anyone as part of large generalized caseloads that are managed by folks who have no particular expertise, interest, or training in mental health. So this was a matched trial. We had 180 probationers per site, and we matched the jurisdictions in their mental health resources. We matched the offenders in characteristics that we know predict recidivism, and we used this really cool thing called propensity scores to statistically control for any differences between those groups that remained. So we followed them for 2 years before they started specialty or traditional supervision, and we've got between 2 and 5 years of follow-up data on them at this point. So we interviewed their officers, the probationers, 3 times, and we've got lots of record-based follow-up data beyond that. And we had really good retention thanks to great interviewers in this study. This is the way we can get as close as possible to approximating an experiment. Experiments are the very best research because you have people randomly assigned to the treatment or control condition. We can't do that here, so we matched them as best we could while we were recruiting them. And then we used the statistical procedure so that if we had a higher risk group in traditional and a lower risk group in specialty, we apply those propensity scores so that we're weighting them and we're comparing people who look the same. So that if we see any differences, it's a function of the treatment, not a function of who is enrolled. Does that make sense? Good. All right. So here's the big deal. Again, we've said that new crimes and new victims are really the primary outcome for this group, and that is best represented by arrests. Better represented by arrest than revocation. So what we did first is we looked at whether they were rearrested within 2 years of their placement on probation. And what we see is that if you were in traditional supervision, you were over twice as likely to be rearrested compared to if you were on specialty supervision. These are FBI arrest records. They're state-of-the-art. They're capturing everything. And we're controlling for propensity scores. So this looks like it had an effect. Not only an effect, but a pretty big one when it comes to criminal justice interventions. If we look at how long people were able to survive in the community without reoffending, they didn't actually die, but surviving in the community without reoffending, you can see that those in specialty supervision, more of them stayed in the community, and they stayed in the community longer than people who were in traditional supervision. So again, about twice as likely to succeed over that 5-year period if you're on specialty mental health supervision compared to traditional. So this is exciting. And we place this in context by basically saying it's not a function of arrest rates in Dallas or LA. We can take that into account, and that doesn't explain it either. If we look at violation reports that were sent to the court, these are usually grounds for trying to get people revoked. We see a similar pattern where if you are in traditional supervision, your officer is 2 times or more likely, sometimes 3, to file a violation report with the court than if you're in specialty supervision. Now, as I said earlier, we were excited about these effects, and our first assumption was, well, we know that people in specialty supervision are getting a lot more treatment than people in traditional supervision. The program was working as expected, as it was supposed to on that front. But then, as I mentioned before, we found that the effects weren't explained by symptom reduction. So again, if we look at baseline 6 months and 12 months, where were their symptoms? We can see that their symptoms were coming down, which is good. So they were improving, but not by much, and not differently as a function of whether they were in specialty or traditional supervision. So it doesn't seem to be much of a symptom effect. This is a pretty disabled group. It started that way, it stays that way, and that doesn't seem to be the reason for the reduced arrest. I searched and searched for an effect here with better measures and looking at functioning instead of symptoms, and there just isn't anything there. We also looked at change in substance abuse symptoms, thinking, well, maybe there's a dent in substance abuse, and that could be partly responsible for the effects. But we're not seeing a difference as a function of sight on substance abuse either. We also found that boundary spanning was important, but the criminal justice effects weren't explained by boundary spanning. You're asking yourself, what is that? What is boundary spanning? It's a concept that Hank Stedman actually brought to this field as really, really important for this population. If you think about them, you know really quickly they have mental health problems, substance abuse problems, criminal justice problems, housing problems, social services needs. It goes on and on. So there are multiple systems involved, and the idea is that if you have an advocate, that's my favorite word, someone who will advocate for these services and try to make sure that people don't fall through the cracks. I've actually seen specialty probation officers on the phone with HMOs and third-party providers trying to get people a bed. So the idea is if you do that, it's a really essential part of a specialty program. What we found when we measured this systematically, based on how knowledgeable the officer was about other systems, how helpful they were in service linkage, how much advocacy they used, we found that that made a difference when it comes to how many services and how many different types of services people accessed, but not ultimate criminal justice outcomes. So that brings us to the 4 factors that we think are important, 3 of which we have direct support for in this study and 1 we have indirect support for. The first is officers, caseworkers, really, that's what they are, seem to be implicitly targeting at least some criminogenic needs. And we have recent evidence for this based on a study that we did in Maricopa County on specialty probation. So we recorded meetings between the caseworkers and their supervisees, and we simply focused on what are they talking about? What are they addressing? And what we found was that one thing was talked about far more than anything else. What was that? You know it. Mental health. So, yes, thank you. So in virtually all of these meetings, all of them, mental health was discussed. How are you doing? Are you taking your medication? What's going on in treatment? So virtually all of the time that we kind of approach mental health as a master status. It's the thing that defines these people above any other status they have. Father, offender, etc. So that was addressed virtually all of the time, but we also coded how often they were talking about the central 8, those criminogenic needs that you saw earlier. And what we found was that a fair amount of the time, they talked about the kind of moderate risk factors for crime. So in about 40% of meetings, they did talk about financial issues, family and marital issues, accommodation, so actually sometimes, not always, housing can be an issue, and substance abuse. So if those were criminogenic needs for those individuals, that was probably really helpful when it came to recidivism. And I guess you can read this as half empty or half full. I'm a clinician, so it's half full. We also saw that in a minority of cases, they sometimes talked about the real big risk factors for this group. So impulsivity or emotion control, hanging out with antisocial peers and trying to hang out with more pro-social peers, antisocial attitudes. So this is important. There are also big exceptions to this. We had one of the officers who was terrific by all accounts. I think half of my lab was in love with this officer and how well his interventions were and how well they went for most folks. But there are occasional blind spots. So he was talking with an offender who happened to be a sex offender with serious mental health problems. And he was about to finish his term. So he was doing sort of discharge conversation with the person and asked what his plans were after release. And he said he was going to Thailand. And the officer said, wow, what are you going to do there? Well, there are nice women there, and I'm going to spend some time and see the sights, et cetera, et cetera. And rather than, I think he might have been doing paperwork at the time or just sort of going through the motions, but that went right by. That was a perfect opportunity to address a criminogenic need, and instead, the feedback was, that's great, everybody should have plans, it's time to have your reward for having done so well on supervision, etc. So there are opportunities that arise, and 9 times out of 10, he probably would have intervened. But it's important not to let them go by. The reason it's important to let go of mental illness as the thing that you focus on first, second, and third is that in the general corrections literature, we found that when officers, people, spend less time checking lists, doing paperwork, did you attend treatment? Did you take your medication? Did you pay your fees? Da-da-da-da-da. If they spend less time doing that and more time discussing those criminogenic needs, recidivism is reduced. So in this study by Jim Banta, they did something similar to us where they recorded meetings and they focused on how often those needs were addressed. They had an advantage over us because they had actually assessed individuals to see what they needed help with. As an example here, we can see that 34 of the 72 offenders had criminogenic attitudes identified as a problem for supervision. It was discussed in less than 10% of cases. Less than 10%. Peer problems, 20%, that's a little bit better. You can see that other topics are addressed more often, substance abuse, family marital issues, etc. But here's the important thing. When very little time or no time was spent discussing a criminogenic need, 50% recidivated. When a lot of time was spent discussing a criminogenic need, 3% recidivated. This is a small study, but it still suggests that it's really important to focus on what's driving the criminal behavior. The second thing that we found, and this is directly in the probation study, is that what you do to try to get the person to comply with the rules, including the treatment mandate, the way that you do that is really important. So in our early work in probation, when we talked with officers and we talked with offenders, we heard different ways of dealing with noncompliance. So when we did a national survey, we described Mike, who was a 29-year-old probationer who was taking medication for voices he hears and the delusions that he had that people were trying to harm him. According to the vignette, Mike had stopped taking his medication, he hadn't shown up for one of his probation appointments, and he'd been missing treatment as well. We asked supervisors across the nation, what would the typical officer in your agency do about this compliance problem with Mike? And we heard in both that survey and in our focus groups kind of a traditional approach, which went something like this. Bark at him. Chew him up one side and down the other, basically lie to him and say, you're looking at prison. This is something that we came to call the big bluff. Actually, Hank Stedman labeled it this. So the standard, easy, efficient intervention when it comes to noncompliance is to use a reminder or a threat. If you don't shape up, something really bad's going to happen. The reason that we refer to it as the big bluff is because it's very hard to find a judge who will revoke based on treatment noncompliance or failure to appear alone. And once the offender knows that nothing's going to happen, they don't really feel like they have much left in their repertoire. We heard a non-traditional approach that we have since come to call problem solving. So an example is talk with Mike to identify obstacles to compliance. Maybe he can't get to treatment because he needs a bus pass, for example. Remove those obstacles to compliance and then agree on a plan. And the plan has consequences for noncompliance. So this is really problem solving. This is consistent with the general correctional literature where problem solving is really advocated as a much more effective approach than sanction threats alone. And the reason I'm telling you this is because we found in our study of probation and mental health that the way compliance is encouraged or enforced is really important. So we asked both officers and probationers about what their officer did every 6 months to try to help them comply with the conditions of supervision. So we had some non-traditional approaches that are really close to problem solving. So talked with you to figure out reasons for problems, listened to what you had to say, came up with a solution, etc. Praised or rewarded you when you followed the rules, so there's some positive reinforcement here. And we also have sanction threats, which is more like asked or got the judge to put you in jail for a short time, asked or got the judge to revoke your probation, scolded or punished you, etc. And what we found was, first, bad is stronger than good. It's good, in theory, to do problem solving, but what really makes a difference is whether you're relying a lot on sanction threats. So when we had people who were relying a lot on sanction threats, they were more likely to be arrested and more likely to be revoked. I point out the arrest because this is criminal behavior that officers don't necessarily monitor, manage, etc. So it seems to be a real effect. And it's a real effect even when we control for how high risk the person was or whether they were misbehaving. So it's not just that, you're yelling at the people who are already being bad. It seems that the yelling at part seems to actually predict arrest and revocation. Okay, I'm going to speed up a little bit. And we found that those in specialty supervision used a lot more problem solving and a lot less sanction threats than those in traditional supervision. So more problem solving, less sanctions. And that partly explained why they were more effective. The thing that we found is perhaps the most important in this study is establishing strong dual role relationships. Here's the thing. If you come from a clinical background, you were probably taught to avoid dual role relationships. They're bad. You shouldn't do them. The fact of the matter is, when you're working with someone who is required to take part in treatment, whether they want to or not, you have a dual role relationship. People in probation have recognized this for a long time, and they've also recognized that the way that you navigate your role as both counselor and cop can be really critical in how effective you are with individuals. Because in order to really change behavior, you have to have someone who trusts you enough to disclose problems. And to do that even knowing that disclosures of really big problems or of the wrong kind could result in consequences that are not so favorable to them. So we did a study to define what relationship quality is in these situations, and I'm going to cover it really briefly and then get to the point. We heard about authoritarian relationships. These, by the way, apply not just to officers. They can also happen if you're a mental health worker working with someone who's an offender. So we can have things like, the first time I met him, he threatened to put me in prison. I got so damn scared, okay, and I didn't do anything. The first time I met this officer, he let me know he owns me. On the other hand, we heard about relational relationships. So actually, the first question he asks when I step into his office is, how are you doing? And he really wants to know. We all need encouragement sometimes to do the right thing, and it's okay with me as long as it's done in the right way. Talk with me, first of all. I know Spanish, I know English. There's no reason to roll up in the paddy wagon if you think that I'm going in a direction that you feel is going to be harmful to me. She talks to me the right way. So we created an inventory that really seems to get at firm, fair, and caring relationships. So we have authoritarian characteristics on the one hand. So from a probationer's perspective, I feel that X is looking to punish me, puts me down when I've done something wrong. In contrast, we have something that looks more like procedural justice and an alliance. I know that they want to help me, they treat me fairly, they consider my views. If I'm going in a bad direction, they will talk with me, etc. And the reason I'm telling you this is, and this is crucial if you come from a clinical background, this is not the same as the therapeutic alliance. So being firm is part of this. Using the rules is part of this. It's not just how much you like each other. When we look at how people describe their relationship, it actually tells us something about what's happening in meetings. When relationships are poor, there's lots of confrontation and resistance. When they're better, there's more following. And, as you'll see in a minute, it predicts recidivism. And we found that this is true whether you're mentally ill or not since this time. And it does that even after we control for how at risk people are or how difficult it may be to establish a relationship with them. So, for both arrests and revocation, if you have a firm, fair, caring relationship, you're less likely to be arrested, you're less likely to be revoked. We see those good relationships more often in specialty than traditional supervision. And this is a fancy way of showing that if we look at the effect of specialty supervision on a criminal justice outcome like revocation, there's, moderate effect. If we take into account the dual role relationship, it explains that effect. So this really does seem to be an important part of why we're effective when we are effective with this group. The last thing I'll talk about is I think that programs can be really important for reducing stigma-based decision-making. We tend to approach offenders with mental illness with the usual assumptions that they are uncommonly likely to be violent and need to be kept on a very short leash. And we see this whether we're talking about correctional officers or the general public or probation officers. And that can lead us to decision-making that is not always fair. So this is one quote that we had from a refreshingly honest probation officer, right? If there's a nutso on my caseload and he's taken up too much of my time, when there's an opportunity to transfer him to another officer, I'll transfer him. So the idea here is that mental illness can relate to recidivism not through risk necessarily, but through reduced thresholds for revoking people, whether that comes from the officer or the judge. And we have some data for that, but I'm not going to cover it because we're out of time. So really quickly, what are the implications for practice? The one thing that I try to convey to people is that ex-novation is your friend. So if you're coming from a traditional law enforcement point of view, it's important to ex-novate low thresholds for revocation. So if you're sending an individual, or if you're a clinician and you're asking to send an individual with mental illness back because of treatment noncompliance, for example, when that definitely wouldn't be the case for someone without mental illness, it's important to think through that carefully and ask yourself whether this is an appropriate action or not. It's also key to avoid reliance on sanction threats and think more about problem solving, to try to establish firm, fair, and caring relationships with offenders, and finally, to let go a little bit of the mental illness focus and think about criminogenic needs. It may include mental illness, it may not. And I'm going to skip this and say that part of the Council of State Governments materials that you'll find out there actually present a model for moving beyond the one dimension that we tend to think about with this population to consider another dimension. So the one dimension that we always think about is how sick are they? To what extent are they ill? To what extent does that cause impairment in their functioning? And there are evidence-based mental health practices out there that we know work for those individuals for public health outcomes. The other dimension to think about is criminogenic risk. So hopefully you use tools that assess risk and get at criminogenic needs so that you have an idea about whether this person is low or high at risk for recidivism, and you can do something about it. So I'll just point out two dimensions of this. Let's say we have someone who is low in clinical needs and low in risk for recidivism. Leave them alone. Really, if you're trying to save resources, and maximize impact on both public safety and public health outcomes, if they have good enough supervision and good enough treatment in the community, they'll be fine. They came to you fine. Most of them will leave fine. Where the resources really need to happen is where you have someone who is both high risk and high clinical need. And here you need to bring all of the resources to bear, whether it's evidence-based mental health or evidence-based corrections. So here, an example would be risk-need responsivity and integrated dual diagnosis treatment. And this guide is outside, and I'm going to end there. Thank you.